You functionally trained both of us.
Yeah.
Like Amit was your resident.
No.
All right. Welcome back to the OuchCast.
Thank you.
Thank you.
Glad to have you guys. I know we've talked about some of this stuff before, just between us, and I've been around some of these discussions when we first started seeing this stuff way back when. But today we're going to be focusing on ultrasound therapeutics, and I'm Neal Rakesh again with the OuchCast, and I have two special guests here as well. I have Dr. Gulati, one of the cancer pain docs in New York, and I have Dr. Michael Gofeld, one of the founders of WAPMU as well, and he is one of the prior pain physicians back in Toronto. Is that right?
Yeah, that's right.
We affectionately call him Grandfather Gofeld now.
Grandfather. Like, figuratively and literally, right?
Yeah, you functionally trained both of us.
Yeah.
Like Amit was your resident.
No.
It was a very quick no.
No, but
He's always been a good mentor, but I didn't train with Mike.
But I met him when he was still a trainee.
Yeah.
A trainee was chutzpah.
Yes.
All right, let's get into it. Let's talk about ultrasound therapeutics. What is that? I'm familiar with physical therapy, and people use ultrasound as a means it's a modality for essentially like alleviating any kind of muscle pains. It has a better penetration, kind of deeper. People use it for delivering medications as well. What is ultrasound therapeutics? What does that mean exactly?
I mean, we're looking at using ultrasound waves and the energy of the ultrasound wave to have changes in the soft tissue, on bony surfaces. We're taking advantage of the increase in energy of those waves. And you can see some of those thermal type changes. You can see changes with gas bubbles. And so we take advantage of that to deliver a medication, like you said, to change tissue, heating, and obviously you have some blood changes as a result of that, increased blood flow. So a lot of great options with ultrasound energy. And the beauty of it is, unlike, say, a radio frequency needle, you don't have to pierce the skin. And I'll let the grandfather pitch in some of his stuff too.
Yeah, I still remember doing radio frequency 12 gauge, blunt needles.
12 gauge?
12 gauge, ray electrode, 12 gauge blunt needle.
That's crazy. Did you sedate them?
Oh, yeah. Yeah.
That's
how radio frequency started, like in Australia with 12 gauge ray needle. It was 3 or 4 hours operation. They would take a coffee break in between patients.
And they were smoking in the ORs at that
probably,
time?
Yes, I know.
You're functionally taking a pen and you're just sticking it in there.
Yeah.
That's crazy.
Yeah. Wow.
So what is it like now? Obviously, this is so vastly different. No needles.
No needles.
And what can we use this for? Obviously, you've already said, Amit said, that we could use it for a lot of different things, but how can we apply this in the pain world?
Sure. I think we need to step back and where it started. So it started from MRI guided, high intense focused ultrasound. Two companies were in the market. The procedure was technically very successful, but it took 2 to 4 hours in scanner. Enormous expenses. Patient needed general anesthesia just to keep them quiet. Nevertheless, it was first attempts to treat bone tumors, prostate, breast.
Oh wow!
Yeah, and then it was not really successful. It took off until they discovered that actually it can treat brain lesions or like functional. And then it took off, and now it's it's approved, at least in the regulatory. It's approved now for essential tremor and some other movement disorders.
Wow!
But still, it's an MRI system, right? So now it was out of our reach as pain doctors, right?
Yeah.
For obvious reasons.
Yeah, we're not doing MRIs on people. And it sounds like gamma knife. That sounds like a gamma knife type thing.
It's like a gamma knife, just using different energy. But
right.
So basically, it doesn't really matter if you focus energy as a conus, whether it's light or ultrasound or some other energy. It's actually when the conus brings it together in a peak, it will create a burn or lesion. obviously depends on an amount of energy, right?
Yeah.
So now fast forward, there is an opportunity now to minimize it and do portable, intense focused ultrasound.
Oh, that's interesting. Yeah. So you could do this in the clinic, is what you're
Well,
saying.
so that's our goal, right? So, I mean, just like Dr. Gofeld has said, we're able to focus ultrasound. So unlike a conventional device where you use ultrasound for diagnosis and sends the beams forward, just like a magnifying glass, now we can focus it at a certain point. So all the ultrasound waves meet at a focal point. And that's the point that heats the tissue.
All I think about when you say a magnifying glass is like you used to burn ants on the.
It's
on the
pretty
road.
much.
It's all the same.
Yeah, it's
It's
pretty
a
much.
small
Wavelength of light
child,
is a
just-
wavelength of
It's pretty
sound.
much.
Yeah.
So the cool stuff was, I think, with high intense focused ultrasound is a physical property that when you focus it, and contrary to MRI that you need to do bifocal to focus it in the soft tissue.
Yeah.
If you do unifocal, within about an inch of the end of the conus, when and if the beam meets a bone, it will create a lesion on the surface.
Oh, so it automatically kind of identifies this. It
Yes.
cannot penetrate
There's
this
some
bone.
of course, some physical and biophysical protocols, but in essence, it will be still defocused. It will be a mild warming, but when it meets a bone, which is in the majority of cases that we treat, that's a goal, like facet denervation, for example, it will automatically focus and create a lesion about 1 centimeter in the shape of the Hershey chocolate.
Oh, wow, that's awesome. And you're not worried about boring a hole through the bone.
No,
It's just
the
impossible.
bone actually protects you. Because whatever's behind the bone takes the energy, the vibration happens at the surface of the bone, and so the temperature change happens at the bone. So anything behind the bone will actually stay the same temperature more or less.
Yeah.
The ultrasound waves do not penetrate.
Except if you change the protocol, then you can do intraosseous lesions, which just started as work now.
Oh, wow.
Yeah.
That's now this. I mean, functionally from obviously in the world that Amit and I are in, that's a cancer based thing, and that sounds actually very interesting. Even the bone aspect of it, periosteal lesions. If you want to kind of ablate some of those nerves, then you can get periosteal things, which we tend to get a lot of times with these lytic lesions.
And also the beauty of this, unlike an RF lesion or a cryoablation probe, you can make these smaller lesions with ultrasound as programs. You can make these amorphous shapes of lesions. So and if your tumor, for example, is not the shape of a ball, but instead it's kind of like an amoeba or something, you can kind of do these targeted lesions under MRI guidance or CT guidance, and you will get you'll get the whole volume ablated, but you don't have to put a bunch of different probes to do that. And so there's a lot of possibilities with this, with high focus intensity ultrasound.
So this is called high
intense focused ultrasound.
HIFU. Okay, that sounds fun to say.
Yep.
And then the
say it 3 times fast. HIFU.
It's like a karate term.
Yeah.
So there's high intensity, and this is functionally what we do for ablative technique. So this is for someone that's doing this now. When we say doing in the clinic, we're talking about medial branch ablations. That's a common thing that people would do. Is this what it's being used for what you've seen so far?
Yeah, I mean, now it's a medial branch or any facet degeneration is sort of low-hanging fruit. So that's basically where it started. And the most clinical evidence comes actually from Europe, from Germany and UK. They've been using for quite some time with MRI guided. Now we jumped and started studies with using the portable device, and the first pilot study is published last year in Pain Medicine.
This is new.
That's new. So it was only 10 patients, but the results were encouraging. Basically, no difference between RF and HIFU results.
Oh wow! So a non-superiority study essentially.
Well, it was a pilot study. It was safety.
Pilot study.
But
Okay. So safety
it's a safety study.
Okay.
So now the study in Canada on 30 patients is almost done. The results are kind of the same with the radio frequency.
Yeah.
It will probably get us to the Health Canada approval, and it will be first started in Canada. Sorry, United States.
Our study is going on in the United States now. So
but the United States is picking up because United States now, based on FDA rules, it has to be done multi-center, randomized, double-blind study. So it's started now with 10 sites.
I'm not sure all 10 are enrolled, but
10 or 12 sites. Multiple sites and very robust, rigorous protocol.
Yeah.
Similar kind of to the protocol of Paul Dreyfus used in his first radio frequency study.
Oh, interesting.
Yeah. So hopefully we expect that 2023 will be approved in Canada and in Europe, and end of 2024 in the United States.
I'm getting the sense that Canada sounds better than the United States, is what you're trying to say.
I'm not trying to say. I'm just saying.
You're not biased at all.
No, not biased at all. But device studies is much easier to do in Canada, similar like in Australia system, than in the United States. To get approval and vice versa, it's easier in the United States than in Canada.
Oh, that's crazy.
Yeah,
that's a weird.
Yeah, that's a weird situation.
It's a weird reversal.
Yeah. So we use kind of both worlds, right?
Yeah. No, I like that. I mean, obviously it's a joint venture, because I think even when I was a resident, I had seen you two kind of tinkering and trying to understand this and do this better. So this is kind of, we're reaching like a point where things are starting to happen and
we definitely practice in the animal model, the swine model, the pig.
Yeah.
And definitely kind of optimize some of the settings, make sure that the ablation occurs where we want it to occur. We're doing that now with ultrasound guidance as well. So now we can try to do HIFU lesions, not just with fluoroscopic guidance, but with ultrasound guidance, and actually see the surface of the bone and have some, accurately lesion.
So not only is it, you were saying portable, the system is portable, now the entire process of doing it is portable. You can do it with ultrasound, which people can do, in any clinic around the world.
So imagine, first of all, ultrasound system is I think it's the coolest part of ultrasound system is automatic.
Yeah.
So it's automatically focusing. The second part is even more mind-blowing because you do the same probe you use for imaging and for emission, right?
Oh,
so you don't need anything else. You just need a cradle.
And it doesn't create like an interference pattern in any way?
Well, with the lesion's on, you'll see it in the ultrasound imaging. You'll see ultrasound waves going through when you actually make the actual lesion.
But it does not create because the whole system is augmented reality.
Oh, wow.
Yeah.
So that is pretty interesting. So you're able to...
So basically in animation mode. So you do first image and real image, real life, either fluoroscopy or ultrasound, and the rest is a virtual reality.
Oh, that's interesting. So you're not in any way altered as you're doing it. You can still reliably maintain that that thing as you're doing it. And that oftentimes would probably be the issue. Once you, especially with ultrasound, once you alter something in the beginning, it makes it functionally different. So you inject in that air or saline or whatever you're putting has completely altered the structure of it.
It all depends on your frame rate, right? You can within a second you can do a lesion and then see the image and then do a lesion you're basically doing like off and on of the imaging and off and on of the HIFU. Yeah. And so you can watch it in real time.
Plus, we're not injecting anything, right?
That's true.
Right?
It's funny because I feel like we get into the weeds of this. This is like the engineering, and this is like this is the next time when we come back, we get really deep in this. I want to touch on, so you said this is called HIFU, the high intensity version. Is there something called LIFU, the low intensity version?
Yeah, so much more commonly actually, and much older in technology is actually low frequency. So using frequencies, and actually it's not necessarily frequency, which is 1 megahertz or 3 megahertz. It's really the acoustic intensity or the watts per centimeter squared.
Right.
And you're just more energy than conventional diagnostic ultrasound. So you're allowing tissue to get more ultrasound waves, and you're going to generally heat tissue, especially to the bone. And so that's called LIFU. And I think it's being used for many, many years. And we are using it really for neuropathy of the feet and the hands, which has really been beneficial, similar to what they do in Alberta, Canada. So both of us kind of had this idea at the same time and released our data independently showing that patients who have chemotherapy-induced neuropathy are improving just with LIFU. And obviously, we're not trying to lesion the foot or the nerves of the feet, but you're increasing blood flow. You may be causing things like acoustic cavitation and some effects in macrophages and fibroblasts that are maybe less understood. Yeah. But in the end, that increase in blood flow may be helping the foot heal, but it definitely does seem to improve the feeling of neuropathy, makes them walk further. We have that data along with our colleagues in Canada as well.
And plus, remember the all systems of life or conventional ultrasound that's been used in, as Amit said, in physiotherapy forever, they defocused. So you hit the joint and you don't really know where the energy concentrates. So with this more focused system, with ultrasound guided, you can concentrate on a specific tendon, a specific bone, nerve, without affecting, without actually making any lesion. So it's much more focused. There's also ultrasound or LIFO-assisted regenerative medicine.
Oh, interesting.
So basically, you hit the tissues and you increase blood flow there, and you can inject some regenerative substances, let's say, and they will be preferentially absorbed in this tissue, opposite to other part of the body. Right?
And this is reminiscent, is kind of what I was saying when people were using this before in physical therapy, or they're using it for drug delivery.
Yeah, that's the drug delivery.
Yeah, drug delivery is very different, but obviously you're encapsulating drugs in different particles that when they're exposed to ultrasound energy, they'll vibrate and then rupture.
Yeah.
That's what ultrasound is doing. Yeah. And you can focus it in either intravascularly, you can have devices that are intravascular. And so you may have a drug circulating through the entire body in these little vacuoles. And then when they pass the ultrasound energy, they might rupture, and that artery may be heading towards the liver, for example, or the pancreas. And that's where the drug is alluded to. And the concentration of that drug could be higher at that end organ, and it'll be not concentrated in the rest of the body. So you can focus your gemcitabine, or you can focus whatever chemotherapeutic agent to the distal organ, as opposed to having to go to the rest of the body to get to the concentration you need for the death of the cancer.
Another aspect of LIFO is diagnostic. So it goes back, way back to biophysics lab in the University of Washington. Pierre Murat is a good friend of mine and colleague. Initiated, they call it TAP, transacoustic palpation.
TAP.
Yeah, so we did TAP. So
they really come up with these interesting acronyms to make it sound very childlike.
The experiments were done on rats, on neuropathic model, inflammatory model, and then actually was one experiment done on the fingertips of our colleagues to whether you feel it, and basically there kind of the idea is to stimulate nerve tissues for diagnostic purposes. Let's say, now we do medial branch block, right? Yeah. Let's imagine we don't need to do it. We put a LIFO ultrasound or LIFO X-ray guided system, and we stimulate the same nerves, kind of mocking the pattern of the facet-generated pain, and then bringing this to diagnosis. Plus, possibly we can block axonal blockage without destroying the nerve.
I guess what we're trying to say is that you can change your intensities of the ultrasound, and you might have reversible conduction blockades. They're basically allowing a nerve to heal after a couple of weeks.
Interesting.
You might not do complete coagulation of a nerve. You may, quote, stun it.
So it's almost like a pulsed RF, or like a
it's probably more like a long-acting local anesthetic.
Yeah,
I like that. That's a simple way to say it.
It's like not high-fu and not low-fu. It's in the middle fu.
Middle fu.
My fu. There we go. You heard it here first.
The beauty of this is that with acoustic intensities, we can really change. We can have gradations of change in soft tissue, whether it's a nerve, whether it's other cells. We might encourage, for against the pancreas, to release insulin at certain temperatures. We might destroy the islet cells if their higher temperature is really high. And that's the beauty of ultrasound. We can really control the amount, the waves that are coming and the intensity of the wave to have different effects. And that's where when Dr. Gofeld is talking about this, that's where the research is really going. In pain, we're looking at an ablative idea. Maybe in regional anesthesia, when we can think of conduction ideas with MIFU or high LIFU or whatever you want to say. That's the great part of looking at the studies from Washington with and Dr. Foley, and looking at the sciatic nerve and seeing these changes, reversible, then not reversible, depending on the intensity you choose. And that's the fun part of this for our young generation when they look at ultrasound. It's not just diagnostic anymore. It's really high-end therapeutic. And there's a lot of opportunity to understand and really apply this to the pain field, whether it's musculoskeletal, neuropathic, et cetera.
Plus, if you think about the field development, a few years ago, this Focused Ultrasound Foundation, they published all reports. So a few years ago, the field that was going very fast up was oncology. Like now, it's pain.
Oh yeah, that's interesting.
So it's
very different now.
It's exponential elevation of this field in the clinical and more research. It's so I think it will be I don't know if it's replaced other devices or other methods, but it will be definitely a good addition. Imagine patients like don't need needles and only really feel pain after.
Yeah.
We've been doing ultrasound, destroying renal stones and bladder stones. We've been doing these kind of things, but to be able to focus it and apply it in very small areas of the body is what really is making this very unique.
So the future is bright.
All right, so we've talked a lot about these different options, and I want to kind of bring it all together just to kind of make it easier. So we have LIFU and we have HIFU,
and MIFU.
And MIFU. Sorry, we have MIFU. We forgot about MIFU. All FU. And the best part about this is it's all you're doing is you're varying the intensity of it. Probably to some degree, there's a variability of frequency depending on the depth and what you're trying to achieve, but they all have different purposes. One, you can obviously do LIFU as a therapeutic purpose, as you said, for neuropathies, for the chemotherapy-induced neuropathies, and various feelings.
Musculoskeletal injuries, yes.
Yeah, and then Michael, you brought up the regenerative aspect of it, which is real interesting. So utilizing that with other medications, like whether it be a regenerative therapy like PRP, that's cool as well. And then we have the MIFU, which is in kind of the middle range where you're doing different things, maybe even activating it or turning it off like a local anesthetic, which I really like that comparison. And then we have the HIFU, which is essentially the higher grade, the heavy duty thing where you're just, let's kill this, let's ablate it. And that, again, we talked about how mobile it is with an ultrasound. You could do this at any clinic, you could do this anywhere, and there's no needles.
That's the future.
That's the future. Did I adequately bring all of them? Was that all the types of it? Did I miss anything?
That's pretty much. I think there will be also a role of the intense focused ultrasound. I don't know which range, but intense focused ultrasound in neuromodulation and functional rehab.
Oh, interesting.
We can talk about
I think you find ultrasound assisting a lot of different medical situations. Being able to turn on the temperature to get you to 42 degrees, 41 degrees makes a difference in a lot of states in diseases. And so we might see blood flow improving infection. We might see wound healing improve. Like there's other things that this can be applied to. That's where the future is. How can you focus ultrasound energy to make your therapeutic, whatever that therapeutic, medical therapeutic or medical treatment is, better? And I think you're seeing that with all variations of ultrasound. I
almost don't want to say this aloud because I feel like this is something we should like copyright, trademark, or whatever, patent. But what if you took a lead and you put like piezoelectric crystals in it, in like the conventional stimulation lead, and that's what you're implanting? There's no degradation from the electrical current. There's no fibrosis that's formed. It's like the whole premise of optogenetics, stimulating neurons with light, which we're doing with an ultrasound.
Well, you need to take it offline.
It just sort of come in that way. That we cut.
I mean, if you continue this line and someone will pick up, you can probably early retire.
That's how you make millions right there.
People are talking about that already.
Let's talk about just to close it off. What's the future of focused ultrasound therapies? Where do you guys see it going? Obviously, I assume the thought process is this is going to become readily available to the general population. Where do you guys see this going?
So the first immediate goal is to finish studies on HIFU denervation.
Yeah.
Or HIFU ablation of facet joints,
right?
Sacroiliac joint, because again, it's a low-hanging fruit and it's work in progress. Mm-hmm. The second will be probably a leap to do a joint denervation, because we all know like knee denervation with radio frequency is
exquisitely painful.
It's painful and it's not ideal. And people claiming like 4 nerves, there was actually 13 nerves around the knee, and hip and shoulder. So, truth to be told, we still need something to alleviate pain in a palliative sort of. I mean, I'm not talking about cancer, but palliative setting of osteoarthritis,
right?
As a bridge to surgery or no surgery. But the next step is, as Amit said, will be a development of ultrasound guided HIFU with automated automatic focusing.
So you're not going to need pain doctors anymore.
No, you need a pain doctor.
Because
we need to write the prescription.
What you're going to see is like what's happened in every other technology. You know, we used to use handheld phones that are big, and now we have an iPhone. And so we're going to see
without promoting anymore, right?
Yeah. Oh, oops.
I mean, you didn't say the company.
That's true. Modular smartphone.
I feel like you're saying, you know how every movie with anyone that says we're going to have robots take over this and do that. You know how they end, right?
Yeah. Remember, so I want just, remember
we'll always be the robot.
the Star
Fellows
Trek
will be the robots.
Like, remember Star Trek? Yeah. When and the guy goes into this brain sort of surgery, like done. So that's kind of HIFU, that what it looks like. Right?
And this whole brain HIFU, there's all sorts of really cool ideas coming from this field right now. And so you're going to see a lot of these ideas. And the main thing is going to be, how can you modularly deliver this so that a lot of people can apply it to their patients? Right now, it's just systems are a little bit bulky. The technology is just going to get more streamlined and modular. And when that happens, you'll see the explosion of ideas of how to apply it to their patients.
Yeah, it's inevitable. We had giant
so
TVs and
the fun part is all
small.
of us are in the phase of seeing that happen, and we're going to watch from the development phase to the clinical utility, and ideas are going to flow from there. We're in that middle phase right now, and that's what makes it a lot of fun to be a part of.
I like it.
Yep.
Thanks, guys, for stopping by.
Well,
I learned a lot today, and we're definitely gonna come back again, and we're gonna see how far the data, the research is, and then maybe we'll talk about some of the papers at some point.
I'm sure everyone wants to listen to it.
All right, take it easy, guys.